Since 2010, there has been a lot of research that has just come out about unconventional masturbatory techniques in men and how it impairs their sexual functioning and relationship. But even today, when doctors talk about sexual difficulties, they, especially erectile dysfunction, they focus on medical ED and psychogenic ED. They rarely talk about how problematic masturbatory techniques can cause sexual functioning. Why do you think this resistance, or rather, reluctance on the part of doctors to talk about this?
Yeah, it's a great question. Masturbatory techniques, I think you're right, is something where there's more and more research done on it. I think that there's been an understanding amongst urologists, at least for quite a while, that can play a role in erectile difficulties. But outside of urologists, who tend to be a little bit more comfortable talking about sexuality, I think one of the real core issues is that medical doctors, regardless of the country or type of degree, they get so little training in sexuality. And it's not specific to medical doctors. You can say the same thing about clinical psychologists, is that it's just not a focus in most graduate training programs. And so without an introduction and a sort of desensitization to talking about topics surrounding sex, it's hard to do. There's nothing inherent about having an advanced degree that makes you more comfortable talking about these topics than anybody else is. So unfortunately, one of the things that you hear a lot as a sex therapist is that people have gone through 10 stops before they get to you, and at multiple stops along the way, they've talked to medical providers who either shut down the conversation or make it very clear that they have nothing to offer there. So I think that's issue number one. I think issue number two is that, and again, I don't think this is specific to medical doctors, but any sort of care provider, if you have a hammer, you look for nails, right? I mean, you sort of you use the skills that you have, and you really try to emphasize those causes. And so if your main emphasis is on specific types of medical problems, you will search for evidence of that, and you'll sort of downplay other things. And I think this is one of the reasons that clinical psychologists are particularly well placed to treat sexual difficulties, because as a default, we tend to use biopsychosocial thinking. So we assume that pretty much any difficulty that comes through our door is a result of a combination of biological, psychological, and also social causes. Absolutely. And that to disregard any one of those three categories is not getting a complete picture of the problem.
Absolutely. Doctor, in your practice as a therapist, I know you also do a small private practice as a therapist. So how common is this issue relating to masturbatory techniques have come up in your assessment?
Yeah, so, as you mentioned, my private practice is pretty small. I spend most of my time teaching, training, and doing research, but I've certainly seen it a number of times. And I think it's an interesting question, because I think the framing is really important, and the narrative that folks have for themselves about, what are the causes of this sexual problem, really shapes how equipped they feel to address it, how motivated they feel. Right. And I think that the automatic framing is often, well, this is the way that I've masturbated for so long. And so my option is to try to just brute force, by force of will, sort of overcome that, or to fix it in some way. Yeah. And I think it really speaks to the basic way of viewing sex. And I think that as a psychologist, this is really sort of where you get a lot of the improvement, is focusing on, okay, so it seems like the implied statement in there is that for sex to happen and for it to be okay and satisfactory, there has to be an erection, there has to be an orgasm, and that has to happen at a certain speed, frequency, etc. Yeah. And so much of the willpower goes towards, how do I meet those standards of performance? Yeah. And if that's the mindset going in, is that I need to perform or else something really bad is going to happen. Yeah. It almost doesn't, almost the harder you work to meet those standards, the worse it gets, because you're already in the mindset that is not really facilitating of enjoyment, safety, connection, intimacy, like the things that people want about sex. So oftentimes the conversation is started by folks of, how do I fix this problem, right? How do I fix the fact that there's a mismatch between how I masturbate and what I experience during sex? And the follow-up question is usually, let's talk about why this seems like a problem, right? Like what is the meaning tied up in this perceived mismatch to you? And to the degree that a new mindset is internalized of saying, my partner and I, or partners, whatever the configuration is, we are a team. And we have shared goals of, we want to feel pleasure, we want to feel connected with each other, we want this to feel safe. Those more abstract, flexible goals have 1,000 ways to get there, right? And so it becomes less of, we need to fix this problem or else, and more of, hey, let's get creative and brainstorm and think about, how can we jointly create the sort of sex life we want? And if that really is the mindset, then oftentimes it's easy. It's not impossible. There isn't some sort of hard physiological barrier that prevents some sort of response in a lot of different contexts.
Also, Dr. Men who engage in unconventional masturbatory techniques like death grip syndrome and prawn masturbation, they often end up desensitizing their penis progressively, and which eventually leads to a situation where they don't experience any sort of sexual feeling in a relationship. So how do you think we can address a situation like this? Do you think the accessibility and availability of anytime porn, has actually worsened the situation?
Yeah, so I think these are two related but distinct issues, and one is this sort of desensitization, and I think it speaks to the importance of getting a comprehensive assessment of the various causes of erectile difficulties. So I'm sure I don't see many of these, but I'm sure there are some cases where there is some specific physical or medical injury that has been done to the penis, where there is a sort of strict ceiling on erectile function. And this is probably not that dissimilar from prostate cancer survivors. I mean, there's a variety of medical conditions where no matter what you do, the erection is now off the table to some degree. Which does not have to then equate to the end of satisfying sexual experiences, because it gets back to this question of, is there this rigid set of beliefs and assumptions about what sex has to look like? So I think that's sort of one issue where before it gets to a sex therapist, or in conjunction with a sex therapist, ideally there is a wraparound assessment of, let's see what the physiological limitations are. And I think that can happen in connection with pornography use, but that's sort of a whole separate and fairly complicated area. Joshua Grubbs is actually a researcher that does a lot of great work in this area of sort of compulsive sexual activity and porn use. And it's not my area of expertise per se, but I think the take-home message from a lot of that work is that like most sexual activities, there's nothing inherently problematic or harmful to sexual function or sexual interactions about pornography. It is the ways in which it is used and the stories people tell themselves about it. So if pornography use results in a narrative that a person has that I'm a terrible person and sinful and have no control over anything, for whatever reason, if you're thinking those things about yourself, that's not going to facilitate positive sexual interactions. If the pornography use leads to a set of beliefs of this is how sex should be or needs to be, right? So one of the common examples of that is, well, I watch pornography and every male actor in those videos has an immediate erection. It never shifts. It never falters. It somehow goes on for an hour and a half. And that is seen as real. That is seen as the minimum standard of satisfying sexual activity. Or the types of activities that often, most pornography is created by men and is not overly interested in female sexual pleasure. So if the activities in pornography are taken as a manual for how to do sex, then those are sort of the issues, right? It's sort of the secondary and tertiary effects of pornography use. But I think a lot of what I do in my practice is make that distinction of saying, like, listen, I'm going to start from the baseline of as long as things are consensual and you're not harming other people, anything is fair game. And let's start there and talk about why does this seem to be such a problem for you. because that provides so many more avenues of intervention, rather than we need to improve your willpower to not do this, which is often a recipe for disappointment.
Absolutely, absolutely. Also, doctor, relating to what you just said, porn is often kind of punching back for more this conservative-minded people who look at sex as problematic in the first place. So, one related question which I want to ask you is: a lot of people say that youngsters have told me this, that when they watch porn too much, they experience erectile dysfunction, porn-induced erectile dysfunction. So my hunch is can be maybe due to the problematic or the excessive the death grip syndrome, or the kind of masturbatory techniques which they might be habituated to. I don't know. I'm just asking you if there can be a reason. That can be a reason for that.
I'm sure that can happen. I'm not aware of good research out there about a specific correlation between frequency, type of pornography use, and style of masturbation. I feel like there's a variety of masturbation styles that can happen with or without pornography. So I think it just speaks again to having a good nuanced evaluation and conceptualization of what's going on, right? And this is another spot where I think clinical psychologists have a bit of a privileged position, because we don't have 20 minutes to talk to the person. We don't have the pressure often to maximize the number of folks through our office. So it's less about us saying, what's the easiest thing to do and what's my sort of first line thing that I can throw at it. It's saying, let's sit down with this person. Let's think about not only the variety of causes, but how they all fit together, and then work collaboratively to say, which of the possible ways that we can approach this is most feasible, resonates most with you, has the best evidence. In situations where it's this combination of a lot of pornography use that is having these negative consequences, which again is not inherent in the use, to try to identify what those links are. Like, what is it about the pornography use that is leading to this type of masturbation style that then seems to be a mismatch with what's happening with your partner? And asking questions like, why does that have to be a mismatch with your partner, right? Like, what is the barrier, for example, to incorporating this pornography and the style of masturbation into sexual activity?
Yeah.
And so if the answer there is, well, I couldn't imagine because I'm so ashamed of everything that's happening, it's like, well, that's probably more where we're going to get more progress, right? Is instead of fixing this problem, it seems to be a problem because of what it seems to say about you. And you're right that can start to overlap with a lot of, sort of conservative, sex negative ways of thinking, which in and of themselves, as clinical psychologists, it's not our jobs to say how you should think or believe.
Absolutely.
But it can be helpful to have somebody that collaboratively is saying, if you have this set of beliefs, there's probably an upside to those, right? You wouldn't have them unless you felt like they were doing something for you, but there's probably also a cost to them. So instead of just on autopilot continuing to carry along with those, why don't we talk about, where did they come from? What are they doing for you? What are they costing you? And let's make an actual mindful decision about the best set of beliefs that fit with your broader set of values and that actually get you what you want.
Absolutely. You highlighted a very important aspect, talking about issues. But that is actually not easy, especially when the case of men, when they go through a sexual difficulty in a relationship, they often withdraw from sex and again go back to porn rather than figuring out what exactly is the problem and trying to address it. Why do you think this happens?
Yeah, it is hard to talk about things that are embarrassing, that feel shameful, where there's any possibility of somebody reacting negatively to you. Humans are sort of an inherently social species, and it's aversive to have people react negatively. And if it's something that you feel badly about, and if you never talk to anybody about, it makes all the sense in the world to assume that someone else is going to react negatively to it, even if it's literally their job not to. Right. You can try to convince yourself that it's going to be fine, but that emotional part of your brain doesn't tend to listen very much to that. This is certainly not unique to sex, but it's really anywhere you go in therapy. I talk about this with my students frequently. I say, if you want to try to boil down what you're trying to do as a therapist as simple as possible, it's that somebody's probably coming in and they don't want to think or feel something. And what they're asking for usually is, how do I not think or feel this? And it's a difficult conversation to have, to say, I see the efforts that you've been putting in to not think or feel this. It seems like they're not working for you. Instead of us just trying harder at these things you've already been trying, what if the real alternative path forward is to allow yourself to think and feel these things? And to do that not in a shaming way, but it makes sense. It is a natural human response to, you touch a hot stove and you get away. Absolutely. You feel a bad feeling, you try to get away.
Absolutely.
And that's unfortunately what causes a lot of the problems, right? Is that people engage in this avoidance of these thoughts, these emotions, the physical sensations, and it has a short-term benefit enough for them to keep doing it, and it has this long-term cost of nothing ever really changes. So much of your job as a therapist is to provide this rationale and this roadmap to say, this is why it may not be working to try to stuff these things down and avoid them. This is an alternative pathway that tends to help a lot of people. I am here to help guide you if that's the direction that you feel like you want to go. And then really just to stick with them, because some people, it takes a while for them to take that jump. Some never want to make it. But when they do, it's really helpful to, at minimum, have a witness there for that process. You can never make it easy, but to try to provide the support where at least they know that there's another human there, sort of as a bit.